Hi, I'm Dr. Brian Kaufman. I'm a family doctor, turned patient and turned patient advocate too, working at the ASH meeting in 2013 in New Orleans. And it's my pleasure to be working with a couple more experienced advocates who've worked in the CML space. Or do you want to tell us a little bit about who you are and a little bit about your organization? Can I get you to introduce yourselves, please?
Yes, it's my pleasure. Thank you. My name is Giora Sharf. I'm a CML patient for almost 14 years, and I became an advocate for CML almost immediately after I was diagnosed, just about a year after. So we started by establishing the Israeli CML patient organization 12 years ago. And in 2007, me and three more colleagues, one of them is sitting right next to me, a very close friend, Jan. We are both being treated by the same doctor in Germany. We started what is a CML Advocates Network, which is an international platform for 82 patient groups of CML and leukemias in 64 countries. And we've been doing a lot of activities among the CML advocate leaders around the world.
Jan?
Yeah, my name is Geissler. I'm a CML patient now for 12 years. And I joined the phase 2 clinical trial after my diagnosis because the current treatments were not approved at that time.
And what was the medication you got with that?
I got in the beginning pegylated interferon and Gleevec in combination. And I did that for a couple of years. And then again, the 25 people in my phase 2 trial started to stop treatment. So we were one of the first really stopping TKI therapy, and I've been just on interferon since.
Wow. So one of the reasons you're here is you had a paper accepted to present on one of the biggest issues. My understanding is the leading cause of resistance to imatinib or Gleevec is that patients stop taking it. And I think you guys were aware of that and did some research on that. You want to tell us a little bit about your motivation and what got you into this trial and what you were finding there?
Yes, adherence, as you mentioned, is one of the top issues of living with CML today, because CML has been turned in the last 10 or 15 years from a fatal disease into kind of chronic disease that you have to live with it for the rest of your life. You have to take a medication, a pill on a daily basis, and that's not easy, especially when you have side effects and you have other causes which makes life not very simple. So there have been some scientific researches done by doctors in Belgium, which is called the Adagio study, and one in London by the Hammersmith Hospital, which have proved that about 30% of the CML patients are not taking the medication as prescribed. And also there was a direct link between the not being adherent to the outcome of the treatment. And it has been proven that patients who are taking less than 90% of the dosage have only 20% chances of reaching a good response, which we call major molecular response. And if you take more than 90, you have more than 80% chances of reaching the same response. So there was a clear link between non-adherence and outcome of treatment.
That's incredible just to think about there. So patients essentially know that they can control their cancer with taking a pill, and yet 30% of them don't take that pill.
Exactly.
Yeah.
And it doesn't make sense. I mean, for a reasonable person, it's this is a life-saving drug, and why are you not taking it? So
and that's what you researched, yeah.
So that's exactly what we wanted to find out, and that's why we started our research. It was done on two arms. It was really a global research, international. We used our network of the CML patient group all around the world, and we recruited online responses of more than 2,100 patients who went from 79 countries, went and answered the questionnaire about adherence. And because we were a little bit concerned that maybe those patients who are recruited by patient organizations, so they are members of CML patient groups, maybe they are more educated than the rest of the CML community out there, and also they are internet users because the internet was the main means to recruit the patient. Maybe they are have more knowledge about the disease, so maybe they don't represent the real CML community out there, so we decided to make our life a little bit more difficult.
So yeah, that would have been my thought. The first critique is the people that you can reach on the internet that are involved, they're advocates, or ones who are hurrah, you know, they want to take the medicine, they want to do the right thing. So you recognize that too and you responded?
Yeah. Yes, so what we did, we actually ran parallelly an identical questionnaire, hard paper copy, with the support of 3 CML doctors, hematologist organization in Italy, France, and Germany, where patients were given during consultation the identical questionnaire in a pre-stamped envelope, and then they just went home and they answered the questionnaire, dropped it in the mail, and then it was sent to our logistic agency who did the analysis, an independent agency who did the analysis. So that's how we received more than 2,500 responses from CML patients. And that's when we started to do all the analysis. We did it in a very short period of 3 months, the collection of all these responses. And I think the findings are very, very interesting, and I think we have a lot to learn from that. And what I want to stress, even though it was for CML patients, we believe strongly that it represents not only CML, and it's good. The findings are as good for other diseases, because adherence and issue is the same issue as many other diseases where you have to take a daily medication. So I think that there is a lot to learn from it.
And one of the interesting things why we did this research was that even though there was clinical evidence of non-adherence, in our patient support work we saw that a lot of also doctors were in denial about the fact. So they said, well, my patients have cancer, I don't think my patients are being non-adherent. So we wanted to have really solid data about that, and so that's why we did the research, and that's also why we did, for example, a validated adherence scale, which has been in use in diabetes and in other diseases and has proven to be valid to both cover intentional and non-intentional non-adherence. So people that are taking the drug because they forget about taking it, or are not following the schedule non-intentionally, or those people that really take drug holidays and think, I want to feel well on the weekend. And we not only wanted to, let's say, see what the issues are, why they're not taking it, we also wanted to look at the tools. So what can we do about it? What role does the doctor-patient relationship play? What kind of tools do they use for reminding themselves? What role does routine play in their daily life? Because people need to live with a disease for decades and need to take drugs every day. And so we need to understand what kind of tools we can offer as patient support groups as well to drive adherence, and what we can advise to doctors.
Well, there's so many things I want to respond to, but one thing as a physician I've got to respond to there is it's sort of classic, you know. Well, out in the community, the rest of the patients may not take their medicine, but my patients, my diabetics, they always do exactly what I tell them, or my cancer patients, they're always doing what I tell them. So I think you're right, there's kind of this sense of denial, or some might say even arrogance on the part of some of the physicians, believing that their population group is going to be different than the rest of the community. So I think what we're going to do is kind of shift into the results that you've found here. So let's pause for a minute here, and then we'll start up again in a minute and just kind of go over what you did find in this study. Thanks.
Sure.